Welcome to the Ripple of Change podcast, searching for our quadruple aim, where we highlight, celebrate, and extol others creating positive change in healthcare and beyond. I'm Dr. Otten, in some circles known as Dr. Rotten, and in other circles I might have been known as Dr. Evil. But we don't need to get into that today. I'm thrilled to have actually two colleagues with me today, as I recently took a part-time job with emergency care specialists. I have Stephanie Mullennix and Todd Chassee here, who told me that his kids sometimes emphasize the middle part of his name. I won't spell that out. I'll let you look it up. But they're a nurse and an ER physician. And frankly, I love the group I joined. Physician-led, clinician-led. They think outside of the box. They challenge the status quo, and they absolutely embody our quadruple aim, which is patient experience, quality care, lower costs, and provider wellness. Incredible. I read about them in the book twice, actually. I'm so impressed with the work that they've done. So we're gonna warm these two up a little bit because they're not podcast regulars. So I'm gonna throw a Ripple challenge question at them right out of the gate. When I used to interview nurse practitioners, one of my canned questions was, who is your favorite superhero and why? And we're gonna start with Todd.
My favorite superhero and why? I'm going to have to go with Batman because he's got really cool cars and cool gear. Not that the other superheroes don't, but I'm going to be a Batman fan for sure. No offense to the other superheroes out there.
That's fantastic. I love that. And Stephanie, how about you? What would you say?
Well, I feel like as a woman, I have to go with Wonder Woman. I mean, why would I not? She has a fabulous outfit and she can do it all. So I think that is definitely my answer.
Beautiful. I love that. And ironically, maybe this inspired me today. I'm a big Spider-Man fan. With great power comes great responsibility. And I feel like with our roles that we have in healthcare, we need to take that into consideration on a regular basis for sure. So without any further ado, I'm going to toss it over to Stephanie to give us our first question regarding the RightCare Clinic. And you know what? I do this every time. I screw up the starting point of these shows. I forgot the title of the show. Thinking Outside of the Box, RightCare Clinic. So there we go. Stephanie, to you for the first question.
Well, we'll forgive your initial flub there. But I think that's a great title for our session. And I think my first question for Dr. Todd Chassee is to really walk us through what the inspiration or the genesis was for the RightCare Clinic. So, Todd, do you want to elaborate?
Yeah, no, great question, and so glad to have Todd Otten part of the team. We'll see is the newest employee what he thinks after working for us for a period of time. I think it's a great question because why would a group of emergency physicians who make our primary living seeing patients in the emergency department in a fee-for-service environment, why would we think about a venture to open a facility outside of the ER and see patients? And I think this is really part of a transformation story for our group. We have incredible, leadership for our group, hired, fantastic staff. Stephanie leads our quality team. And so this is not a, idea that came from nowhere. This has been a slow evolution as we start to work towards the quadruple aim and, move towards value. And so we started to think outside of the box of emergency medicine is the four walls that we practice within. And so we started to practice within observation medicine and, continuing care for patients who are in the hospital for 1 to 2 days. We knew that we were experts in sedation, providing sedation services. No surprise to any of the clinicians out there, huge needs in substance use disorder and behavioral health. And so as we started to move into all of these different areas besides just traditional emergency medicine, I think we discovered a couple of things. One, emergency physicians, we believe, are very well positioned to thrive in these roles. And the other thing that we realized, there's a huge gap. There's big opportunity as we look to improve the patient experience, quality, and provide value. And so I would say this is really a long time coming, and I have to give credit to our CEO, John Troop. He is the one who's had this vision and has really helped lead the evolution. So this was not a rash decision to to open this clinic 6 months ago, this has really been a transformation story over at least the past 10 years for ECS.
I think it's amazing. I've known the chief medical officer, Chris Port, for a long time. We went to school together. And over the years, he would tell me about some of the adventures that ECS was working on. And it would just warm my heart. And frankly, we had chatted about a year ago after I'd stepped away, and I really wasn't ready to take on a job. But then I started missing patients. And really, probably the only group I would have went to even consider working for was ECS, in part because they do things differently, and they think about how it affects the patient. They think about value. They think about quality. They think about all these things that we should be doing. And it's just incredible to be part of the team. Sorry, Stephanie. See, I already jumped in. It took me all of 60 seconds to interrupt things.
It's an exciting topic, right? And I think a couple of things that Todd said are really important. And I think kind of that slow, gradual build, especially, as a contributing member to the team, I think that oftentimes people have strategic goals that might be far-fetched or too aggressive. I think ECS really totes the line in that space really well. And I think there's a lot of intentional planning and competency work that went into getting us ready to launch this clinic, right? Small steps to advance our skills outside of traditional emergency medicine. Todd talked about the observation unit, sedation. Over the last couple of years, we've really been focused on trying to provide better care for our patients after they leave the emergency department through an ED virtual aftercare clinic, right? We know our patients can't achieve the follow-up that they need in a timely manner. And so we were able to, I think, slowly dip our toes into this care outside of the four walls of the ED before we were really ready to take the next steps and really embrace the full model. So I think that strategy, and as Todd mentioned, really our president, John Troop, gets some credit for that. That strategy has been very, very beneficial. And I think it's going to help make our initiative very successful.
As you guys talk about this, it makes me think too, even though this is an evolution for the group, I think one of the other things is that we're a group that's not afraid to be different, think different, try things. And compared to some of the partners and other, leaders in the healthcare industry, we can do this relatively quickly. So this is a gradual transformation for our group. But when it comes to opening a clinic like this, it doesn't take 15 committees and 10 years of planning. We're not trying to build the perfect, model here. We're willing to try something to pilot. We have failed at other initiatives before. We've tried telehealth a couple of times. Stephanie already mentioned, innovation. We do virtual follow-up visits for emergency department patients. And so slow evolution for the group, but we also have the ability to pivot, to pilot, to try things. And if we fail, it's okay. We have plenty more ideas where this one came from.
And that is such an important concept, right? The ability and the permission to fail. I think that gives your team the willpower to move forward, the ability to take risks. It's such a powerful statement, and I think really part of what makes our group as successful as it is.
I think that's amazing. And actually, one of the skills I've learned recently is a failure bow. If you've never done a failure bow, actually Joshua Judy, my co-author, and I, we gave our first keynote. And right at the disclaimer, I was like, well, there might be some errors in this keynote. We both gave a failure bow right then, and everybody was laughing. Oh, it was great. Stephanie, I know you've got more questions for Todd regarding maybe some of the intricacies of the clinic. And there's a pyramid, is sort of the descriptor that is on some of the information that shows that the gap that this clinic is intended to fill, if you will. I'd love for you to maybe dig into that some.
Yeah, Todd, I think that you're well positioned to answer this, but I think it would be helpful for the audience to understand really what is the care model for the RightCare Clinic? What gap do we think that it is going to fill in the community? And why is ECS well positioned to address that?
Yeah, great question again. And I think, we think about the pyramid that Todd's referencing. At the top of the pyramid is emergency services provided in an acute care hospital. That's not going away. We need, to have these facilities available. This is where we do our primary work. And if you need resuscitation, for patients, absolutely, it provides a need in the community. It is an expensive resource because you have to have that readiness to serve. as emergency physicians, we see many patients in that high cost, plenty of resource scenario who are going to ultimately be discharged. And so for those patients, great resource for them, but not the value. And so patients who could be seen in a lower intensity environment, especially where they still have the expertise of emergency physicians. Just below, and again, the RightCare Clinic, we might use the term urgency center. I like to think of it as either urgent care on steroids or kind of ER light. And so it kind of falls in that gap there. Below, urgent care, and urgent care really depends on the area that you live in. The area where we practice here in Western Michigan, urgent care has very low level of services. You're not going to get laboratory studies. You're not going to get CT scans. And so conversely to patients who are going to be seen in the ER and discharged, we know that there's many patients who the minute they arrive at urgent care or their provider directs them to urgent care, they're ultimately going to get sent to the emergency department. And so if you're a patient who's in their 40s with chest pain, there's a high probability that you're going to get sent from urgent care after an EKG to be seen in the emergency department where you can have advanced laboratory testing, troponins, and again, ultimately may be discharged. And so urgent care isn't meeting needs for a good set of patients who could be cared for, maybe not in all of the bells and whistles of the ER, but a center that had the ability to offer that moderate complexity lab testing, CT scan imaging, which would be a big differentiator in our community, plain x-rays, in that expertise of an emergency trained nurse and emergency physician. At the bottom of the pyramid is primary care. We love our primary care colleagues. We are not here to replace primary care at all. We think that is the bedrock for our patients. That bedrock, unfortunately, doesn't always have the capacity to meet the needs of the patients. And so all of these things come together for our vision for the RightCare Clinic. I think it will evolve with time, but really to meet that gap that exists for many patients now.
Well, and I think this is wonderful. As a family physician, I didn't send a lot of people to the emergency room, and usually when I did, there was some really good reason for it. But I can also think of a lot of times where this would have been brilliant to have, where I could hop on the phone and say, "Hey, I'm not sure they're going to get admitted. I want to see kind of where we're at. We need maybe some X-rays, a little bit of blood work." If I had the opportunity to hop on the phone and send somebody to a place like the RightCare Clinic, it would have been amazing in cost savings. I can think of one potentially humorous anecdotal story that might go in here, so I'm going to go ahead and tell it. One of my favorite patients over the years, he had significant cardiac issues, congestive heart failure, whatever, and he had come in with about a 2-week history of really persistent GERD that came on very suddenly and intensely and didn't go away, and maybe got worse with activity. And I can see the wheels spinning in both of my colleagues' brains here. And I told him, I'm like, I'm not sure this is like gastrointestinal. I think this could be your heart. And so we did an EKG in the office, and sure enough, it showed an injury, and he was still symptomatic. So I needed some blood work to kind of see where we were at, maybe an X-ray. And I said, I think we need to send you to the ED. And he said, well, that's fine, Dr. Otten, but before I go, I'm stopping at McDonald's. And sure enough, he did exactly that, because he knew what was going to happen. He was going to get it anyways. I'm droning on, but I thought it was, and there might have been an opportunity there, right? If he goes to the RightCare Clinic and maybe his blood work's not that bad, I could have probably just seen him back and coordinated getting him into cardiology. Anywho, I'll throw it back over to you, Stephanie. I've droned on enough.
That was a great example, actually. And I think it sets Todd up really well, I think, to answer my next question, which, what do you think the RightCare Clinic offers from a patient experience perspective? Cost, comfort, et cetera. How is our care model going to be different than what patients might receive in the emergency department?
Yeah, as I think about this from an emergency physician standpoint, we love seeing patients in the ER. But when we ourselves or our loved ones are patients, we realize, just the experience that our patients have in the emergency department. And so as we design the RightCare Clinic, we want to try and focus in on, things that are in our control that can function maybe different than the emergency department. And so, the first standpoint is just that communication and coordination. Our goal is to partner with primary care physicians, employer health clinics, people who would be referring patients in, and so that there can be that warm handoff for the patient, so we know who's coming to see us. Hopefully we can be able to make sure that we have services to offer for them. I could envision times where we may say, your patient sounds like they need care and they actually need to see my partners in the emergency department. So there's that communication, that warm handoff. This is not meant to be a traditional walk-in urgent care. I'm sure we'll have patients who walk in, but the goal would be to have patients have access to same-day quick scheduling. Someone gave a great example yesterday. They wake up, their child has ear pain. They call their pediatrician. They're not able to be seen. It's 8 a.m. in the morning. They go to the RightCare website and they get a convenient appointment for 9:30 that works for them. They walk in. They're seen right away by our staff. And so unlike, the emergency department where, you may end up having to wait, you don't know when you're going to be seeing that experience where you're basically selecting your time, you get your assessment. And again, being able to offer it in an environment that is more quiet, patient-friendly, and then continuing with the services on site. And so if you need laboratory testing, it's going to be done right there. Results are going to be back quickly. If you need advanced imaging, all of this is going to occur, while you're still in the RightCare Clinic. And then hopefully you're going to be sent on, whether it's to home. If we find something where you need to be admitted to the hospital, we're going to work on that seamless transition where hopefully instead of going to the emergency department, you're going to go right to the room at the hospital. If you're going back to your primary care physician, again, continuing from the warm handoff that we received, making sure that information is transmitted back to your provider so you can continue on your journey. And most importantly, at a better value for the patient than the emergency department services that are offered.
That's fantastic. And I may throw a question over to you, Stephanie, to maybe talk about logistics a little bit of the clinic in terms of availability. And keep in mind that this is opening in July of 2024. And so this is going to be an iterative process to one degree or another. And I'm sure the hours will change over time. But as a starting point, please tell us what the availability will be.
Yeah, so from the get-go, we anticipate that the clinic will be open from about 10 in the morning until 8 at night. So last patient around 7. We think we have some pretty good processes established for patients to access our clinics. We have a very convenient online portal that will be available. And as Todd mentioned, we really want to make sure that we're able to coordinate with the patient's primary care doctor and make sure that we're able to help get the right patients to the RightCare Clinic. So accessible physician communication from that perspective. So we're going to have about 7 treatment rooms at the beginning. And of course, we're staffing with all emergency medicine physicians and emergency trained nurses. So I think it's no shortcoming to say that our team will be experts at throughput. So I think we can expect some pretty expedited processes and efficient workflows for patients and our clinical teams. So I think we're going to do pretty well with our initial setup. And then as we get busier, we fully intend to reevaluate our hours, expand hours into the evening, maybe, earlier appointments, and then potentially add options on the weekends as well. We want to be here to meet the community's needs, our patients' needs, and I think the referring provider and or employer's needs.
Beautiful. And I'll say the logo looks cool too.
Thanks.
The big R that's going to be on the building. Stephanie, was there one other maybe question you wanted to ask Todd? And then I did have one other maybe Ripple challenge question at the end. And we want to make sure that we put plugs in, the website for the clinic and where people can find us and all that kind of thing.
I think the only other thing that maybe Todd could touch on a little bit more is just really kind of the cost comparison, right? So, we briefly mentioned value, but what does that really mean to the patient? What if you're a patient with a high deductible plan? What if you're an employer that's self-funded? What does that value proposition really look like, Todd? Maybe you can elaborate on that.
Yeah, so as we think about the value, obviously comparing it to your other choices, which could be telehealth, urgent care, or going to the emergency department. And, obviously going to the emergency department generates a large bill, and there's the professional charges, the fee that you get for seeing the provider. There is the facility charge that goes to the health system or hospital for having those services available. And that's going to be a large bill. The state of Michigan, you see averages of, $1,200 for an emergency department type visit. And obviously that can go upwards to, incredibly high. And so compared to the ER, this is specialist outpatient codes. And, what does that mean in terms that, much closer to what you're going to pay to go to see your primary care doctor in the office, what you're going to go pay to be seen at urgent care. Obviously, if you have to have additional testing like a CAT scan or blood test, you have those added charges, but it's going to be a magnitude lower than the more expensive option of going to the emergency department. And so from a patient standpoint, you brought up great examples there. Patient responsibility continues to increase, whether it's high deductibles or other aspects of paying for healthcare. And so a cost-conscious consumer is going to be able to look at this and hopefully see the value. From a payer standpoint, or from a self-insured employer, or from an employer who's offering insurance, again, the value is in decreased cost, getting almost emergency department level services without having the full expense of an emergency department visit.
Totally. And I could see, direct primary care is definitely a big movement in this country. And I think part of the solution to some of the issues that we have in the United States, and I could totally see direct primary care clinicians wanting to utilize this on a pretty consistent basis. So this is wonderful. And I appreciate the two of you coming onto the show and providing some entertainment for our guests, and frankly teaching and not just about the clinic, but really teaching about how to think differently and do things differently in the healthcare space in the United States, because frankly the model in many places is broken at best, and we need this kind of thinking to happen regularly, really. So I love it. So kudos to you and the group and emergency care specialists, etc. So having said that, why don't we do one more Ripple Challenge question? There's no rules to this. You can answer it however you want. It doesn't have to be related to RCC. I do them to be fun. So we'll say sutures, interrupted, or running. Todd.
That's like the oldest debate. Interrupted. Running, you get the speed for sutures. I'll be realistic. I think that interrupted is just my go-to. So, yeah, interrupted.
Love it.
I'm going to ask the question back. Todd, what about yourself?
Oh, for sure. Yeah, I like interrupted as well. And I think, my years of being a surgical intern, we did a lot of running for speed and, size of the wound. But in primary care, the majority of things I did were either, punch biopsies or things of that nature. I did do vasectomies, and so you didn't really need running sutures for a vasectomy. I think if you were doing running sutures for a vasectomy, you've gone pretty far and probably need to turn back. Stephanie, do you have an opinion?
I'm just glad we're talking about vasectomies. Wow, that's a turn that I didn't see this podcast going. So
you gotta have some levity in these things, and laughter is so needed in our space, and I do my best to try and inject it a little bit. No, and I know you're a nurse, Stephanie, but you could still have an opinion on this.
I have an opinion on this.
Yeah. Let's hear it.
You do a great job putting in a running suture. Then that's way less removal that one has to do. There's nothing worse than trying to dig out 25 sutures from somebody's poorly cared for wound. So, I'm for a running suture if a competent provider can put them in.
I love it. It's all about perspective, right? Do either one of you want to share the website for the RightCare Clinic and ECS as well, and then I'll wrap it up?
Yeah, absolutely. So our main corporate website is you can find us on the web at ecs-wmi.com. And the RightCare Clinic website you can find at www.rightcareclinic.org or www.rightcare-clinic.com.
Love it. Well, this was absolutely fantastic. I had a lot of fun, a lot of laughs. It's been a pleasure to work with ECS to this point, even though I've only been there a handful of weeks. As always, I always put in a plug for the book. So here's the book, www.ourquadrupleaim.com. And we'll end with, what positive ripple of change will you create today?
Grab your copy today. Ripple of Change, is available in hard, soft, and ebook formats. More information at www.ourquadrupleaim.com. Thanks for listening, and let's turn ripples into waves of lasting change. Stay tuned to this podcast as we search for examples of our quadruple aim.